So, what is the difference between these cases? Sometimes something is called point of return, and that is somewhat projected back to time. And time here is very important issue. These patients are our patients who come to our clinic. These patients, I will not go through them. They was mentioned before. So I just saw another few cases. Here we see the scattered bone graft in how it looks in the endoscopic surgery. How we have the sinus lift which will combine and it's very well with fiber optic endoscope. How it looks here is the retention cyst and the scattered bone graft in the maxillary sinus. Migrated implant is quite important. Patients coming to our clinic with the migrated implants just to take them out. So we saw here is the implant. Here see the implant inside the maxillary sinus with the infections around. It's important to perform an update imaging before surgery. We use CBCT or 1 day or in the same day because in some cases if you came or bring with all the images, maybe the implant remove or change the position or just swallow or just go on. There was some cases. Oromaxillofacial can also take this from the sinus, open window of the sinus, but in these cases. I want to go again back to the first case of acute sinusitis. You see the sinusitis and she was treated conservatively. But we have another case with grossly scattered bone graft to the maxillary sinus that made sinuses, and he really was suffering. He could not manage with antibiotics, so we urgently operated him. And if you see this muddy bony graft just in the sinus with fistula, so he was operated, both combined operation to oromaxillofacial to close the fistula and doing sinus surgery, only antrostomy. So we can see here with the CBCT after later on he is doing very well. This patient was operated in the past and he has the oral antral fistula. I wanted to show you this nice video just showing the oral antral fistula when the patient was blowing, and if we inserting a seeker, we got this seeker. This patient was treated conservatively with the fistula. Zygomatic implants, they really have serious and severe complications sometimes, and it's very hard to take these implants out. So also we are dealing with this in our joint clinic. Foreign bodies like this crown of the dental in the sinus, and also cysts, lentiginous cysts like for example, or keratocyst. So we are taking them out endoscopically via the nostril, via endoscopic sinus surgery, and we have a very rare case of bilateral lentiginous cyst was also treated endoscopically. So we have here, as Professor Landsberg showed, inferior antrostomy. We are looking, we have this window, and we taking this tooth out of the nose, the nostril out. Yeah, as we see. Okay, so this is the case. We are now taking our dentist, we're doing extraction tooth via the nose, and then this is the CT scan after the operation. Some debates: antibiotic treatment, implant preservation or not, taken out of frontal sinus or not. About antibiotic treatment, Professor Soder said that we are advocate the use of amoxicillin. Implant preservation, yes or no? Some literature advocate just taking out all this implant as foreign body causing the sinusitis, and they mentioning that if it's the foreign body causing the sinusitis, the complications should be out. But our approach is to probing the depth and just to check if the implants are useful or just not stable or bleeding around by oromaxillofacial surgeon. So our result imply that implants removal should be the last option if the implant is not stable, bleeding, and severe repair implant is around it. And the last topic that I want to speak about, the frontal sinus, is needed. Some literature from Italy written that all the sinus should be managed, and also works from John Craig from different as known. Also, most studies advocate that it's described that opening all disease sinuses based on periproliferative should be opened. Another statement of his work. from Israel, Mustafa, they have published 2 papers preserving the frontal sinus, and is written there is conclusion frontal sinusitis is a secondary infection and inflammatory process that will resolve once an underlying odontogenic condition has healed and wide middle and meatal arthrostomy has been performed. I want just to remind you that the work of Mr. Klinger, the osteomeatal complex, the drainage, and this what also that mentioned that we see all the ossified anterior maxillary frontal maxillosinus, but the posterior and the sphenoid are free of the disease. Our protocol: FIS, including maxillary arthrostomy and lavage without frontal sinusotomy, nor ethmoidectomy, are a procedure. Extra care to preserve the inflamed mucosa. Our results, about 9 years old, just only about in 187 cases, only 2 patients needed revision surgery to the frontal sinus because they did not manage the arthrostomy alone. Conclusion. Unilateral disease associated with false milling diagnosis, especially the characteristic of odontogenic sinusitis. High resolution CT and CBCT can assist identifying dental disease. The importance of assessing the oral cavity and dentition in patients with rhinosinusitis is emphasized. Sinus lift is a common procedure to improve maxillary bone stock before dental implantation. Chronic sinusitis is a potential complication of this procedure and may be refractory to medical treatment. Sinus disease related to bone graft and implant can appear months or years with no dental complication. A multidisciplinary cooperation between ED and oromaxillofacial surgeons is advised to provide the best possible treatment. Endoscopic treatment with dental implantation, implant preservation may be a reasonable approach. Maxillary arthrostomy and lavage with mucosal preservation may be sufficient, and there is no need to rush to operate. I have time to show this, Professor Ranchard? Yeah. So I have here the last slide here, just showing a cooperation with this patient came to us, needed sinus lift, needed implant, but there was a dental specification, so it's a little bit with music. So we did the sinus surgery and the sinus lift together in the same operation. We don't see here the music. So we are here doing the arthrostomy alone, in the arthrostomy, and our colleagues doing the sinus lift procedure. So as you see here, so we doing the arthrostomy, taking some pasta, but see, this is the mucosa, is well-defined mucosa, it's not so inflamed, so we would allow ourselves to do the sinus lift in the same procedure. And here we doing our colleague doing the sinus lift, introducing the bone graft, and we are looking at 70 degrees to the maxillary sinus. We can see how they can elevate the membrane, and we can control if there is some perforation of the membrane and the bone graft is going inside the maxillary sinus. And the patient was doing well after that, and we can see that as well. Thank you.
Thank you very much. So actually my part is more questions than answers. And should be a maxillary sinusitis be treated before sinus flow augmentation? This is the question. So I present a case of a 54-year-old female. She's healthy with no background disease. She's asymptomatic without any symptoms or signs related to rhinosinusitis. She's planned for bilateral sinus flow augmentation and future placing of dental implants. And she was actually referred for consultation by the maxillofacial surgeon with a sinus CT. And this is what we can see, obvious signs in both maxillary sinus, maxillary sinusitis. And this was in early August. And this is the endoscopy. As you can see, it's a normal appearance with normal mucosa, no pus, nothing can suggest any signs of sinusitis. So she's asymptomatic. We can consider her as asymptomatic CRS, I didn't know what to do, again, the maxillofacial surgeon insists on treating the so-called sinusitis. So I prescribe her 10 days of oral augmentin, nasal steroid spray. And the problem is that you can't follow because she's asymptomatic. So I had to send her again for a sinus CT and again examination in the clinic. So not surprising, the CT is pretty much the same, and also the endoscopy, as you can see, the same, normal mucus, no signs of sinusitis. All right. So still asymptomatic CRS, and the maxillofacial surgeon, again, I emphasize it, is not willing to perform the sinus augmentation dental implants procedure until complete resolution of the sinusitis. So what should we do? We have a nice WhatsApp team that sometimes we consult with each other, and I asked my colleagues what to do. So half of them said medical therapy and follow-up examination until recovery. I would consider a recovery. And the other half said preventive surgery should continue with fast. And I asked myself, perhaps to tell them to go to a different maxillofacial surgeon for a second opinion. So I didn't know what is the right answer, so I searched the literature, and we can understand why the maxillofacial is worried about mainly about sinus membrane perforation. It's not so rare, and also postoperative sinusitis is more than 2%, and graft failure also it's around 2%. So we need to look for strategy to avoid complication to occur. I searched the literature, and there's not a lot of studies regarding this issue. The only one that I found was published in the Laryngoscope 5 years ago, a group from China, and they actually found more prevalence of sinusitis, and 1% had to undergo FAS. What they do, and one of the reasons that they found is a lot of problem can cause this post-operation sinusitis, but some of them can be preoperative chronic sinusitis. So what they did, they included all patients that had to undergo an endocyst maxillary implant surgery were included. They took detailed medical and dental history, and also craniofacial CBCT. They referred the patient to ENT department. All of them underwent careful history taking and nasal fiber optic endoscopy, and they completed the SNOT 22. They actually divided the CBCT to 6 different groups. A is normal appearance of the CT. B is polyp or cyst less than 50% of the height. C is minor edema, and D, E, and F is different kind of sinusitis. They decided on upfront on strategy on ABC. This the left side only close observation after dental implant surgery. Group 4, continue medical therapy until resolution, and group 5 and 6, preventive phase. So they had 84 patients, average age around 48, a bit more male. The SNOT 22, and this one I want to emphasize, was comparable to a healthy population. It was 14. And that what made this study interesting, because we can say that most of them were asymptomatic regarding the sinus problem. So most of the patients had the A, B, or C, 90%, and 10% had different levels of sinusitis and without symptoms. Okay, so what were the results? 2 patients from, actually most of the patients from group 1 had So some kind of sinusitis, and only one had to undergo FES. And no case developed, none developed chronic sinusitis after the dental implantation. And the discussion, like all of us, we can agree that the ground of preventive functional endoscopic sense surgery is controversial. Perhaps some indication is incurable chronic sinusitis, a large maxillary sinus cyst or polyp, or suspected fungal sinusitis. I want to also to show and I want to emphasize that in the beginning and in the first page, it's still, although it was published in the laryngoscope, it's the level of evidence is 4. So it's not, and then Craig also referred to this problem. The problem is, like Professor Yashar started, it's not a sexy issue, and there's not a lot of publication, and most of the publication, between 90 to 100%, are level 5, 4-5 evidence. So we need, and he also actually referred to asymptomatic patient with odontogenic sinusitis, and it's not rare. It's between 1% to 47% of the patients have some kind of asymptomatic odontogenic sinusitis. And for now, because until high level of evidence, until we will have high level of evidence, if we will have odontogenic sinusitis management, to need to be centers in multidisciplinary shared decision making between otolaryngologists, dental specialists, like Firas showed us nicely before, and we need to discuss the risks and benefits of different dental and sinus surgical treatment options with the patients. Thank you very much.
Thank you. So I think we're going to be on time and have some time for discussion. I just want to add to what Tal just said, that Professor Landry and myself did a retrospective study about asymptomatic patients who were refused by the dental surgeons to undergo any rehabilitation because they had radiologic chronic sinusitis. We treated them conservatively, and when they failed, we operated on them, and we cured the maxillary sinus, and then they underwent, all of them underwent rehabilitation with a failure rate similar to the healthy population. So our conclusion was that surgery, when indicated for this reason, is good. We tried to publish it, but we couldn't succeed because there was no control. However, you cannot have a control because these patients cannot undergo rehabilitation when the maxillary sinus is ill, because the dental surgeons refuse. So it's still a controversial issue, and I hope that in the future we'll get better answers for that. So I just want to finish our talk by showing some complications post-dental rehabilitation. We know that the perforation of the membrane is usually insignificant. However, insertion of foreign material into the sinus cavity or tip of the implants projecting into the cavity may become nidus for chronic infection. This is a case that I treated. You can see on the left maxillary sinus, you can see the sinus lift, and you can see the dental implant projecting into the sinus with some bone chips inside the sinus. This is 6 months after left endoscopic sinus surgery. You can see the endoscopy, you can see a clear normal sinus. So we managed to treat it without removal of the projecting dental implant, and this was, as was shown before, so you can save the implants. This is another case of a patient, 52 years old, healthy. 14 years ago, he underwent left upper jaw implants, and 2 years before presentation, he started to suffer from chronic post-nasal dripping chronic cough, which was unresponsive to any treatment. He was treated by many doctors. Recently underwent two surgeries for repair of inguinal hernia, and now is a candidate for repair of an umbilical hernia because he coughs all the time. But his surgeon, his general surgeon, refuses to operate until he stops coughing. So he was sent to us. Anterior endoscopy and endoscopy, we saw the post-nasal drip. sinus CT scan, we saw two implants projecting into the cavity with pole-grade reaction around the implants, so we thought that might be the reason. However, both the dentist and the patient refused to remove the implants, so I took him to the operating room. And this image is post-endoscopic sinus surgery. You can see the endoscopy, you can see still pus in the maxillary sinus around the tips of the implant. So he still continues to cough. His general surgeon still refuses to operate on him. There's no treatment besides taking the implants out and allowing it to heal. However, he still refuses to take the implants out, so I just sent it to someone else to treat. He still hasn't been currently. This last case, 64-year-old lady, underwent left sinus lift and dental implantation 3 months ago. She was treated with antibiotics for 1 month post-op. She still suffers from pain, foul smell, bone chip is protruding through the nose. That she just filmed it and showed it to me. On endoscopy, there was pus coming from the left middle meatus. This is the CT scan, a typical CT scan of a dentist who ruptured the membrane and just inserted all the bone inside the maxillary sinus, and it always causes an infection. You can also see that his technique was not very good. So we took her to the OR, and you can see the pus coming out as soon as you open the insulin process. Everything was full with pus and bone chips, a very inflamed mucosa. They were cleaned, and she is okay. So in conclusion, complications after sinus lift and dental implantation, when the dental surgeon is qualified or rare, complications were treated successfully. Endoscopic sinus surgery is a surgical modality of choice, and on occasion the implant should be removed, but you can save many of them. So I want just to talk a little bit about now dental origin foreign bodies, and to concentrate on dental implants who were displaced into the maxillary sinus. We did a case series about it. Dental origin foreign bodies may cause odontogenic maxillary sinusitis, and the timing between the intrusion of the bodies into the sinus cavity and the damage that they may cause is unknown. This was the purpose of the study, and there's no consensus on treatment of them, when to remove them and how to remove them. So we wanted to describe the clinical and surgical findings during endoscopic sinus surgery for these removal of these cases. And again, we concentrated